And to moderate this session, I would like to welcome Dr. Shri Ganesh Kamath sir and Dr. Radhakrishna M sir. Dr. Shri Ganesh Kamath sir, he is Professor Neuroanesthesia and Neurocritical Care at NIMHANS, Bangalore. And Dr. Radhakrishnan M sir, he is also Professor in the Department of Neuroanesthesia and Neurocritical Care in NIMHANS, Bangalore. So I just uh, please moderator take the charge from here. Please start the session.
Thank you, Dr. Raman.
Thank you, sir.
Good afternoon, everybody. Senior faculty members, national and international delegate, students, and other participants. It is a proud moment for the Neurocritical Care Society of India to conduct its first virtual conference, and it is a proud moment for NIMHANS for organizing the first oration under Professor G.S. Uma Maheshwar Rao. It is a rare coincidence. In the ISNAC Society also, the first oration was named under Professor Malati, who is from NIMHANS, and even in the NCSCA also, the first oration is from the faculty of the NIMHANS. The proud moment for any academician is to get appreciated by his own teacher in front of the August gathering. So that is why the Department of Neuroanesthesia chose Professor Ruby to deliver this oration, because Professor Uma Maheshwar Rao got trained under him and he was his student. Now, Professor J.J. Ruby is currently the Professor of Anesthesiology and Critical Care Medicine and Director of Multidisciplinary Intensive Care Unit, Assistant Public Hospital, Paris, and Emeritus Professor at Sorbonne University, Paris. He was previously the Director of Experimental Research Laboratory at the same hospital and at the University School of Medicine, Pierre and Marie Curie. He is a reviewer of various international journals in both anesthesia and critical care specialties like British Journal of Anesthesia, Critical Care Medicine, JAMA, and NEJM. He was an editorial board member of Anesthesiology, American Journal of Respiratory and Critical Care Medicine, and Critical Care Journals. He is involved in international research collaborations with several countries, including China, Brazil, and USA. Today is his first virtual visit to India, but he has been physically visiting India since 1993. He is a regular faculty of Indian Society of Anesthesiologists Conference and as well as Indian Society of Critical Care Medicine Conference. Actually, he has visited more places in India than what I have visited. He has visited Bangalore, Jaipur, Varanasi, Trivandrum, Mumbai, Pune, and Kolkata. Till now, he has given around 446 invited guest lectures, including 10 in Brazil, 59 in China, and 53 in India. Actually, when he sent his email as CV, he has written that short CV is enclosed. But when I opened his CV, it looked like a Harrison textbook of internal medicine. He has got around 607 publications in various reputed journals. His areas of interest include renal failure, mechanical ventilation, adult respiratory distress syndrome, inhaled nitric oxide, inhaled antibiotics, and ultrasound in ICU. On behalf of the Neurocritical Care Society of India and the Department of Neuroanesthesia and Neurocritical Care, NIMHANS, I warmly welcome Professor J.J. Ruby to deliver this oration. Over to Professor Ruby, please.
Okay. Okay, dear colleagues, dear Indian friends, it is a great honor for me to say a few words about Professor Uma Maheshwara Rao, who retired officially 3 days ago. You know, after educational qualification in the city of Tirupati in Andhra Pradesh, Professor Uma Maheshwara Rao joined the Niemans in 1982. His major contribution to the prestige of Niemans, to the development of neuroanesthesia and critical care in India, as well as his outstanding medical educational view as a dean of clinical neuroscience, are well known and do not need to be emphasized. What I would like to do briefly is to deliver my personal view of Professor Uma Maheshwara Rao's career. Let me display the full screen. Okay. You know, after medical studies in Andhra Pradesh, he joined, I told you, the Niemans in Bangalore in 1982. In 1986, he was an associate professor in neuroanesthesia. He became an additional professor in 1992, a professor in neuroanesthesia in 1999. He was the head of the Department of Neuroanesthesia from 1996. And he was promoted as a senior professor in 2009 and became the Dean of Clinical Neuroscience in Niemans. I met Uma at the 41st Congress of the Indian Society of Anesthesiologists. It was in December 27-30 in 1993. It was my first visit to India. I'd been invited by the Indian Society of Anesthesiologists to give 2 lectures, one on inhaled NO in severe RDS, and the second one on new mode on mechanical ventilation. You know, because of these dates between Christmas and New Year, I decided at that time to come with my family, with my wife and my 2 children. After I gave the lecture, there was a discussion on inhaled nitric oxide. And Uma came to the desk and started a discussion. He was asking challenging questions, you know. I could not answer all his questions. And at the end of the discussion, he said, okay, would it be possible to come to Paris to have a research fellowship? And I said, okay, let's try. After I came back to Paris, Uma contacted me. I asked for financial support and I got it. And then he arrived on September 30th in 1995 until the 1st of October 1996. No, he was a very, very nice person. He was always enthusiastic in the lab and always positive. Hard worker, never complaining. No, he was working sometimes for 10 days without stopping, including weekends. He was extremely rapid. He was able to understand situation and problems very rapidly with an incredible wit. He was honest and faithful, and he was adopted by everybody. You know, clinical research, he was involved mainly clinical research, interferes with clinical care. So when you come to make your measurements, the nurses, sometimes they're upset. But immediately with UMA, there was a contact. And the nurses, the medical team, everybody was pleased to see him working in the ICU. At the same time, there was Luis Gaillard from Barcelona, and they were working together on the same field of research. And there was Dr. Quinlu from Shanghai, again, working on the same topics of research. In fact, it was an international team. As you can see here, they were working together in the lab, and sometimes one of the topics was the understanding of the right mode of administration of nitric oxide. And all of us went to receive inhaled nitric oxide to understand the mechanisms that was delivering nitric oxide in the patient to have a safe administration. This is this picture. It was taken 1995. He's with a face mask. This is Quinlu, and you know, it's a nice picture. After, you know, in Paris, after 10 to 15 days, Professor Uma Bisquara was taking a day off. He was continuously working. And he visited during 1 year all the cultural places of Paris. This is an example. This picture was taken in the Musée du Louvre in 1996. Another example in the Rodin Museum, and he was staying with Indian friends with a very famous statue, Le Penseur de Rodin, the thinker in English. You know, I have to make a few comments. When he came to Paris, Uma was an additional professor. He was over 40 years old. And he was working with younger people. So he made it. It is very rare to have professors coming to work full-time for research in my lab. He was staying in the university campus, la Cité Universitaire, and then he made some friends. You know, he was incredibly productive. In 1 year, 8 articles were published. Sometimes he was the first author, sometimes the second or the third, in very high-ranked journals. 3 in intensive care medicine, 2 in American Journal of Respiratory and Critical Care Medicine, 2 in anesthesiology, and 1 in critical care. You know, the picture I show you with Luis Gaillard and Uma, they were the first 2 authors of a paper published in anesthesiology. The picture on which is experimenting inhaled NO was published in intensive care medicine. No, it was a very important paper because we understood that we had to synchronize the administration of inhaled nitric oxide with the inspiratory flow coming from the ventilator. Continuous administration was risky, and the risk of producing nitric dioxide was high. Okay, it was so nice. He was so adopted by the group that in August, before he came back to India, we decided that he should take his family to Paris for 1 month, just to visit Paris and some part of France. You know, during my first trip to India in 1993, I came with my family. So I was really excited to giving back this possibility at the end of this research fellowship. So he came with his family. This is Pratyusha, this is Chaitanya, and they are in front of Notre Dame. No, at that time they were still rehabilitating Notre Dame. I can tell you that today Notre Dame is in a very good hand, and in 5 years it should be as nice as it was before. And then he went to La Touraine and the castles of Loire. This is an example, Château de Chenonceau. This is taken in the garden. You know, his wife, Davani, who is an ENT surgeon, came with the children, and they could visit this castle. This is my neighbor. I have a country house in a very small village in the middle of Touraine, in a very wild place. And my neighbor are very simple, not rich people. And they could not speak a word of English. Uma was able to communicate a little bit in French, but immediately between my neighbor and Uma and his family, there was a real contact. It was exactly the same as with the medical team, with the nurses. When you approach Uma, you are immediately seduced because he's empathic. He pays attention to what you're saying, and he makes a lot of benevolence around you. No, this is inside my house, and invited, Davani cooked an Indian dinner. They invited the neighbor, and there was a new Indian restaurant in the small village of Saint-Martin-le-Beau. Now, he went to all the historical place in Touraine, especially the Tours Historical Museum. Now, I came back to Bangalore in 1997, again to participate to a symposium organized by the Indian Society of Anesthesiologists. And with Uma, we run this pharmacologic symposium about alternative to correct hypoxemia in acute respiratory distress syndrome. Now, at that time, the American Journal of Respiratory Critical Care paper on inhaled nitric oxide and Almitris was not published. Okay, then the year after, he became the head of the Department of Neuroanesthesia, senior professor and dean of clinical neuroscience in Niemens. And as you have mentioned, in 2016, Professor Uma Maheshwara Rao received from the President of India the B.C. Roy Award for being an eminent medical teacher. So, you know, he's an outstanding person. He had an outstanding professional career. But you know, maybe the best, the greatest achievement of Uma concerns his children. Pratyusha became an assistant professor of ophthalmology, and she is now working in Andhra Pradesh in the city of Mangalagiri. Chaitanya, his son, was graduated in 2010 in Bangalore. He made a PhD in Maastricht, Netherlands, and in Niemens about epilepsy. And he is right now ending a postdoctoral fellowship in Thomas Jefferson University in Philadelphia. And I think he will move to go on to Houston in Texas. So Uma was not often in the house, but his example was so strong that his daughter and his son became medical doctors. And you know, Davani had also a big role as a mother. And as you know, she's an ENT surgeon. So it's a family of medical doctors. Dear Uma, you can be very proud of what you've done. You were a leader and you provided many, many advances in the field of neuroanesthesia and critical care. You will now have a retirement with your wife, your smooth and sweet wife. This is, I think, a picture of your wedding. And I hope that both of you will be very happy during the next years. Thank you, merci, merci, merci beaucoup for all what you did.
Yeah. Thank you, Professor Ruby, for that wonderful lecture, wonderful presentation about my career and my achievements, much of which was possible because of my stay with you and the knowledge that I acquired from the intensive care unit at Paris. So thank you very much for that wonderful presentation. I also thank the Neurocritical Care Society of India for organizing this oration in my honor. I don't know how much of critical care I did, but I started with a 3-bedded respiratory care ward, which finally grew up to 50-bedded 4 ICUs. And initially, there was no monitoring. We had only a few ventilators that were very rudimentary ventilators. Then ventilators got improved, and the monitoring has reached a wonderful level now. Now we have a direct arterial pressure monitoring, central venous pressure monitoring, non-invasive cardiac output monitoring, and ventilators with extreme monitoring facilities, then ICP monitoring, near-infrared spectroscopy monitoring, EEG monitoring, TCD monitoring, arterial blood gas monitoring, everything. So we admit about 1,200 to 1,500 patients per year to the ICUs. The diagnosis range from GB syndrome to myasthenia gravis to traumatic brain injury to subarachnoid hemorrhage and complicated postoperative patients. And I can proudly claim that the mortality in Guillain-Barré syndrome has reached less than 10% now. This 10% mortality is in patients of Guillain-Barré syndrome who are on ventilator, not the entire group of GB syndromes. And I must thank our nurses for their intensive participation in the intensive care units. And I can tell you they have very rigorous infection control mechanisms, and there is no bed sore in our ICU. I can proudly claim that there is no bed sore in our ICU. I thank the NIMHANS for providing all these facilities for me to carry out my work, and my colleagues in the department who have been a backbone for me. And the important thing that I would like to acknowledge here is the training that I received under Dr. Jean-Jacques Rouby for his guidance. And I also participated in some clinical research, and I could continue that after coming back to India. So I thank everybody for organizing this oration in my honor. So thank you very much.
The last time I came to Bangalore was in 2016. And we met with Uma. And, you know, in the ICU, there was a young woman after a brain trauma, and she was getting lung infection, and she was in respiratory distress. So together, we decide with the Fisher-Pickel help to bring a high-flow nasal cannula machine, and then we went to the bedside and we start using high-flow nasal cannula. Very rapidly, she improved. So I don't know what happened during the following days, but she markedly improved by receiving a high flow of oxygen. We have now data showing that high flow nasal cannula oxygen is efficient in non-COVID RDS. And more and more groups are using high flow with good reasons. I will come back to this point later, in patients with severe SARS-CoV-2 pneumonia. Okay, let's see rapidly what you know, the physiological effect of high flow nasal cannula oxygen. And first, the effect of oxygenation. The main advantage after conventional oxygen therapy is that you know the FiO2 you are delivering to the patient. Now, let's see what happens. If I'm giving 2 liters per minute with a nasal cannula oxygen in a patient that is quiet breathing with a respiratory frequency of 10 breaths per minute, the approximative FiO2 I'm delivering is 40%. But if the patient increases his respiratory frequency, then the effective delivered FiO2 is decreasing. It's true if you give 6 liters per minute. If you use a reservoir bag oxygen delivery system, which provide 15 liters per minute, you know? Why? Because when the patient is breathing, the inspiratory flow is increasing, and then the flow of oxygen you are delivering is mixed with the room air that enters the respiratory system. So with high frequency breathing patients, you would need to maintain the FiO2, but in contrast, you're decreasing the delivering of oxygen concentration. It's very easy to understand. You know, if you are giving a 10 liters per minute flow of oxygen, it is mixed with 30 liters per minute coming from the room. If you give 30 liters per minute of high flow in the nares, then you meet the inspiratory demand of your patient. And if you give 60 liters per minute, you will meet the inspiratory demand of rapidly breathing patients in respiratory distress. There is a small effect on airway pressure. High flow oxygen nasal cannula provides a PEEP effect. But you know, if the patient breathes open mouth, there is a mistake in this slide, then the PEEP effect does not anymore exist. No, if you look at the pharyngeal pressure of healthy volunteers that receive increasing flow of oxygen, then the pressure in the pharynx is progressively increasing with the flow. And if the patient is closing his mouth, then the increase in pressure is much higher. You know why? Simply because the high flow delivered creates a sort of expiratory flow limitation, which create a PEEP effect. Now, if we look not anymore at the pharyngeal pressure, but at the tracheal pressure with increasing flow of oxygen, if the patient is breathing the mouth closed, then you have a positive effect pressure, PEEP effect. But listen and look at the data. If the patient is opening his mouth, then there is no more PEEP effect, simply because the high flow can escape by the mouth and there is no more expiratory flow limitation. So, if you want to get some kind of lung recruitment with high flow, you should have a patient breathing with the mouth closed. What can be used is this kind of strap. It's inexpensive because you go to the patient is comfortable with high flow and you say, okay, the best for you, for your re-education, is to breathe the mouth closed. He said, yes, of course, doctor, I will do it. And then you come 10 minutes later, he's asleep, and then the mouth is open. So again, if you want to get some kind of PEEP effect with high flow, you need such technique. Of course, the increase in pressure is associated to an increase in lung volume. This is inductive plethysmography. This is a conventional oxygen baseline. And then we are going to switch to high flow. You see what happened? But again, all these patients were breathing the mouth closed. High flow has a very interesting physiological effect that has consequences on CO2 elimination. It decreases the anatomical dead space. You know, this is the flow of oxygen in blue during a 6-liter administration of high flow. During expiration here, the exhaled gas is loaded with CO2, as you know, coming from the alveolar space. So during expiration, high flow is washing out the pharynx, the initial part maybe of the airways. So during the next inspiration, CO2 rebreathing will decrease. And by that, you improve CO2 elimination and increase alveolar ventilation, at least the efficiency of alveolar ventilation. You know, in many studies, this is one study about the effect of high flow in patients extubated after a successful spontaneous breathing trial, weaning from mechanical ventilation. And you know, this is the time over 2 days. This is the patient with conventional oxygen therapy and the patient with high flow. No, sorry, the patient with high flow in blue and the patient with conventional oxygen therapy in gray. Of course, the PF ratio is increasing with time. But look at the PCO2. There is a slight but very significant decrease in CO2 from the first 12 hours that persist after 2 days. This is caused by the washout effect of high flow nasal cannula oxygen therapy. Last but not least, the appropriate humidification and warming of the inspired gas makes your patient comforted. Now, breathing dry and cold oxygen through a face mask or a nasal cannula is unpleasant. After 5 to 10 minutes, you feel dry, it's difficult to cough, it is uncomfortable. And one of the secrets of high flow nasal cannula oxygen is to provide comfort because of appropriate humidification and warming of inspired gas. Okay, you know the rules. To provide a 37-degree temperature in cold inspired gas, 24, 22 degrees, you need to provide 44 milligrams per liter of gas administered to your patient. Then you will get 100% relative humidity. If you do that, you keep the mucociliary clearance. You enable the comfortable delivery of high flow, and the patient is happy. Now, again, one of the secrets of the efficiency of high flow is to provide comfort to your critically ill patient. Okay, so to deliver high flow nasal cannula oxygen, you need source of gas, oxygen and air, a blender, and you need an efficient humidifier. You are delivering up to 60 liters per minute. You need to bring 44 milligrams of water per liter administered. You need a performant heater and humidifier. Now, to avoid condensation in the inspiratory limb, you need electrical resistance to keep and to avoid condensation, to keep the temperature high. And you need to monitor the temperature at the end of your inspiratory limb. And there is a retroaction increasing the temperature into the humidifier if here it is going down. Normally, with high flow, you should never get humidity and condensation in the inspiratory limb. You know, some ventilators, Dräger, Air Liquide Medical System, have included high flow delivery system. For instance, with the Air Liquide Medical System, you can deliver up to 40 liters per minute going through the humidifier. So, you know, in the ICU, to have a ventilator already equipped with this type of system is really practical. You do not need to bring another machine around the patient. With the same ventilator, you can provide invasive mechanical ventilation, non-invasive ventilation, and high-flow nasal cannula oxygen therapy. Okay, this is the classical nasal cannula. They are rigid, not very comfortable. So what you need is a silicone-made cannulas that will really be well tolerated by your patient. Okay, now let's move to clinical studies providing evidence that high flow is efficient to treat early phases of hypoxemic acute respiratory failure, non-COVID RDS. There is a study that all of you know. There is Floralis study that clearly show that the early application of high-flow nasal cannula oxygen can prevent intubation in a significant proportion of patients and invasive mechanical ventilation, and the increase in morbidity and mortality associated with invasive mechanical ventilation. Now, it was published 5 years ago. The study was performed, it was a randomized multi-center control study performed in more than 300 spontaneously breathing admitted in ICUs for severe acute respiratory failure. Now the patient, this type of patient, when entering the ICU, normally should be intubated. The majority of them had community-acquired pneumonia. Now, at admission to the ICU, the mean respiratory rate was 33 breaths per minute. And they were deeply hypoxemic. The PF ratio was 144. Again, normally these patients, when they enter the ICU, you provide a small time under non-invasive ventilation, and then you intubate them. In fact, 96 received conventional nasal oxygen with a reservoir bag. 111 received a combination of high flow, 2 hours, in alternation with non-invasive ventilation, 1 hour during the first 2 days. And in 106 patients, they received high nasal flow cannula oxygen therapy alone, 60 liters per minute. Okay, so when you take all the patients together, the rate of intubation was lower in the high flow oxygen group, but non-significantly different from non-invasive and standard oxygen group. But if you take the 238 patients that were the most hypoxemic with a PF ratio below 200, then the difference becomes highly significant. In other words, in the most hypoxemic patients, the use of high flow could avoid up to 25% of intubation and invasive mechanical ventilation. Very interestingly, the mortality rate in all patients, not in a subgroup, was significantly lower in the high flow oxygen group alone compared to the standard oxygen therapy or to the group with a combination of high flow and non-invasive ventilation. This was highly significant. You know, there was an editorial to accompany the article by Michael Mattei from UCLA in San Francisco. He's one of the world experts in RDS. And he entitled his editorial, Saving Lives with High Flow Nasal Oxygen Therapy. Okay, so for the last years, the first line for treating the patients with a medical RDS and respiratory distress is to try high flow. Is this true for critically ill patients with severe SARS-CoV-2 pneumonia? This is our main medical problem now in India, in Paris, in France, in the United States, in South America, everywhere. When you look at the articles, the published article on this topic, you understand that the technique is more and more frequently used in patients with severe SARS-CoV-2 pneumonia admitted to intensive care unit. But you know, we have only retrospective and cohort study. We are waiting for a randomized control study that could demonstrate the benefit, you know, a little bit as the FLORALIS study, the real benefit of high flow compared to non-invasive ventilation. You know, there is a, what you can say, you know, in CHEST, for instance, they have articles called How I Do It. It was published, I think, 1 month ago. And well, they say non-invasive strategy concerns our COVID-19 patients with moderate to mild to moderate respiratory distress. That is a PF ratio between 150 and 300, and oxygen saturation between 90 and 94, and with signs of respiratory distress, mainly dyspnea and high respiratory rate. Okay, so you can use high flow nasal cannula oxygen, starting with the highest flow, 60 liters per minute, with appropriate humidification and warming of delivered gas. One specific point, I'm going back for the last 2 slides on this issue. You should add an oxygen face mask if you use high flow to prevent aerosol dispersion. You know, one technique among non-invasive strategies to treat COVID-19 patients is to ask them to make an awake prone position. And when they do that, to improve their oxygenation, you can add high flow nasal cannula oxygen. It's possible. And 2 or 3 articles have described this technique. The last non-invasive strategy is to use non-invasive ventilation. And then because the helmet has a closed volume, it should be probably considered first rather than a facial mask. How should you monitor your patient you're a COVID-19 patient on high flow. SpO2, of course, regular arterial blood gas, respiratory rate. Now, look, your patient is worsening. Respiratory rate is 28 breaths per minute. Then you start high flow. If after 15 to 20 minutes, the respiratory rate is not decreasing, so you have to be careful because it means that high flow doesn't work to prevent intubation. In other words, do not delay intubation if respiratory rate remains above 30 per minute in your patient on high flow. You know, the ratio between SpO2, FiO2, and respiratory rate, it's called the RUX index, discriminates patients who are successful with high flow and patients, COVID-19 patients, who are in failure with high flow. Your objectives are very simple. Maintain the SpO2 between 90-94%, avoid intubation, try to keep the FiO2 as low as possible, if possible, below 60%. As you know, oxygen therapy is toxic, and your patient has a viral pneumonia with a high permeability type pulmonary edema. Maintain the respiratory rate below 30. Let's go back to the utility of RUX index. Okay, the RUX index is calculated as SpO2 multiplied by respiratory rate divided by FiO2. You know, the limit is 3.85. In those patients, we can maintain the RUX index on high flow. Below this value, the risk of intubation, this is 6 days, is very, very low. But if the patient has a RUX index above 4.88, then please don't delay the intubation and intubate your patients. The last point of using high flow in COVID-19 patients is the risk of aerosol dissemination in the room. If you have rooms with multi-beds, you can contaminate the patients, you can contaminate the healthcare providers. We have experimental data that are very nice. We are published in May, showing that when the patient cough or worse, sneeze, then you have a high velocity projection of aerosol. This is the concentration and the dispersion of aerosol in patients on high flow, 40 liters per minute. And now, if you use conventional oxygenation, there is still a dispersion of aerosol particles, but less far away and less concentrated. Okay, if you put a face mask in this model, then you stop the dispersion of aerosolized particle, maybe aerosolized viral particle within the atmosphere of the room. It has been shown that during coughing and sneezing, these aerosol particles can be projected to over 10 meters in patients on high flow nasal cannula. And in patients on conventional oxygen therapy, they can be projected to 8-9 meters. So there is good reason to use a face mask during high flow nasal cannula oxygen therapy if you use it for COVID-19 patients. Now, some groups, because of the risk of aerosol dispersion, have recommended these canopy systems in ICU receiving COVID-19 patients. We don't use it because it's not very practical. You know, of course, the room atmosphere is fully protected by this system, but then you cannot examine anymore the patient. The communication is difficult. So we think that a face mask is enough. Just conclusion, high flow nasal cannula oxygen therapy in patients with severe SARS-CoV-2 pneumonia may be a good therapeutic option at the early phase of the respiratory distress. Patients are comfortable. You can provide small PEEP effect. As you know, the recruitability of COVID-19 patients is high at the beginning of the disease because they have a ground glass area. They have B lines on the lung ultrasound. So even a small airway pressure can recruit the lung. You can improve alveolar ventilation. The appropriate humidification provides comfort. You can facilitate bronchial secretion removal. And you can combine this technique with the awake prone position. But we need randomized controlled trials to clearly show the benefit of high flow nasal cannula oxygen therapy over non-invasive ventilation. Thank you very much for your attention.
Honoring his oration.
Thank you.
Thank you very much, sir.
Thank you very much.